So Dr. Shulu is one of my mentors and a friend and a teacher and example for many things I do in life. Dr. Shulu went to the University of Maryland School of Medicine in Baltimore, and then he did his residency and in pediatrics and the fellowship. And in Baltimore as well, he joined the Division of Pediatric Endocrinology at Children's Hospital and LSU in New Orleans in 1997. And since then, he has been working on health disparities. And I think he was the first one to describe the disparity between hemoglobin A1C and mean blood glucose in some children, especially African-American children. And from that, so it's already like 21 years, he has evolved with a lot of knowledge in these topics. So he was going to present today. The title for his lecture is The Ecology of Racial Disparity in Glycemic Outcome in Youth with Type 1 Diabetes. Okay, Dr. Shulu, you're in.
Thank you for the introduction. Can you see my slides out there?
Yes.
Slides are there. Okay, thank you. I'm going to minimize myself so I don't have to watch myself talking. And I appreciate you all coming early in the morning to visit. Just wanted to show you part of the newly constructed Children's Hospital in New Orleans, where Ricardo and I work along the banks of the Mississippi River. And a photo credit to Dr. Gomez for this picture. The title of the talk's The Ecology of Racial Disparity in Glycemic Control. And this is a table or a figure that we put together in the chapter by Dr. Maranovich, which goes into the multiple factors that might influence the disease process in our patients. I'm not going to discuss this in its totality, but rather I'm going to focus today on specifically on disparities in glycemic outcome metrics, and particularly do a detailed discussion of hemoglobin A1C. And I hope in some ways this will be provocative and give people there a chance to ask questions or give a critique of this at the end. And I've divided it basically into two sections. One is to talk about biologic factors that we don't consider very much, which may be independent of the blood glucose and seem to have a relationship to complications. And currently it's unclear whether we can modify those factors by current treatment. The second part is going to be management of patients and support factors, which do have a direct effect on glucose levels and hence can modify hemoglobin A1C, and we hope will prevent complications. I wanted to give you a little background on this by going back and discussing a little bit the diabetes control and complications trial. This is a seminal study which asked the question whether normalization of blood glucose levels can prevent complications of diabetes. This is from the study, and the study, as you can see here, was able to keep the A1C at about 7 in the patients that were in the intensive group. And the intensive group were either MDI or pumps, and the conventional group at the time was mixed dose insulin a couple of times a day. And here were their A1Cs, and they were able to keep the difference between the conventional and intensive at about 2%. And here's what the glucose profile sets looked like during the day between the conventional and the intensive patients. And the results of the DCCT, which were published in the New England Journal in 1993, showed that intensive therapy, and what we would call now standard of care therapy, led to reduction of retinopathy by 76%, reduction of nephropathy by 54%, and neuropathy by 60%. And those seminal findings led us to a lot of the current management techniques and approaches that we have today go back to the DCCT, and specifically the rationale and impetus for management to get blood glucose levels as close to physiologic as possible, subsequently led to guidelines that we try to get our patients to with regard to glycemic control. And in addition, it enshrined initially the hemoglobin A1C as a metric to judge management and as a predictor of complications. And one of the reasons, if you go back and see, remember back in 1993 or even in the late 1980s when the study got off the ground, it was very difficult to measure glucose levels in patients. It was also very difficult to get patients to get their glucose levels so that you could assess what the average glucose was over a period of time. It was found it was much easier to use a substance called hemoglobin A1C, which only required one sample of blood and would give you an estimate of what your average glucose was for the last 120 days. Just as a reminder of the biochemistry of this, hemoglobin A1C is formed within the red cells. The blood glucose exposure, the mean blood glucose, is on the other side of the red cell membrane. And all this biochemistry, which is non-enzymatic, takes place within the cell. And just quickly, biochemically, glucose using a non-enzymatic reaction loosely binds to hemoglobin and forms what's called labile A1C because it's easily disassociated. And then with time, over a number of days, there's an irreversible Amadori reaction. And this is what we clinically measure as hemoglobin A1C in the clinics. And it's thought that once this is formed, it's stable and monotonically increases over the life of the red cell. And here you can see from one of our patients, the relationship between A1C and the mean blood glucoses we had from their meter data. And you can see it follows very closely. Don't worry too much about the levels here on the right, because this is the old assay before it was harmonized to the DCCT results. So this assay tended to run a little higher. But the other thing, if you look at a population, as they did in the DCCT, you could see that there was a linear relationship between A1C and mean blood glucose. And very often people would say, if your A1C is, say, 7, it might be close to average blood glucose of maybe 170. And many of you can remember when you would send an A1C, you'd get sort of an estimated average blood glucose, so that even if the patient weren't bringing in glucose records, you might have an idea of what their mean blood glucose was. So here you can see a slide from our data at Children's Hospital, which showed, a couple years after the results of the DCCT, very challenging data that our patients who are African-American, whether they be boys or girls, had clinically and statistically higher A1Cs, which was a challenge because obviously the higher A1C would translate eventually into a greater risk for complications. And in fact, here's contemporary data. African Americans were having higher complications over time. 22 years later, this is data from the type 1 diabetes exchange, after people have set A1C goals and we now have better technology and better insulins, you can see that at any given age, African Americans are still have higher A1Cs than the white patients. And in addition, there was a little paradoxical finding there too, that the African Americans, despite having higher A1Cs, also were prone to more frequent reports of hypoglycemia. Here's a more contemporary look at complications. And you can see, even though there's been a decrease in mortality over this span of time, you can see that African Americans still have considerably higher risk. So what is the clinical relevance of biological variation in A1C for this discussion? I'm going to try to show you what biological variation A1C is. Here's harken back to the DCCT feasibility data. And you can see patients don't align over a straight line, even though the population relationship between the mean A1C and mean blood glucose from profile sets done over a period of a year, there's a linear relationship, but you can see that there's quite a bit of variability. And you can see that at one end of the spectrum, even though all these patients are at 150 milligrams per deciliter, this one individual has a 6, and this one individual has a 9.5, and there's a range in between. So at the same mean blood glucose, you can see that there's quite a difference in A1Cs. And you can find it in your own data. So we looked, and this is from work Dr. Gomez did. Here's a cloud of data. There's a linear relationship you can have, and you can see there's quite a bit of variability here. But if you look at the individual patient, you can see that the relationship is quite consistent within the individual. So the yellow dots show one individual that's consistently higher than the dotted line, which is the regression. And there's one patient that consistently lower, and some people referring to this as someone who's a low glycator, someone who's a high glycator. And then here, a lot of patients who obviously in the population would fit close to the regression line. So this relationship in variability is not random. They don't regress to the mean. There seems to be consistency over time. And if your blood glucose goes up and down, your A1C may be higher and above what the population mean. And you can see the same thing in the DCCT data if you pick out individual patients. Red is someone who's consistently higher, the green someone who's consistently lower. We came up with a metric for this called the hemoglobin glycation index, which is simply the difference between the observed hemoglobin A1C from what would be predicted from the population regression. And here again, here's the definition. You take what you see, what you measure from the regression of the population. It's a measure of the glycation difference, or what we would call biologic variation, at any given glucose level. And unlike A1C, this is statistically independent of mean blood glucose, which may be important if you're doing a multiple variable analysis to see what the effect of mean blood glucose or A1C is when you control it for mean blood glucose. This gives you some directionality. You can tell who's the higher glycator versus the lower glycator. And as I showed you, it's non-random. But does it have a relationship with complications? And Dr. McCarter looked at this using DCCT data. And here are tertiles of HGI. And you can see at the lowest HGI tertile compared to the highest for retinopathy, your risk is about threefold higher if you're in the higher tertile. And for nephropathy, it's about sixfold higher if you're in the highest tertile for HGI compared to the lowest tertile. Now remember, statistically, all these patients have the same mean blood glucose. It's just their variation at that mean blood glucose where they have higher or lower A1Cs. Back to our conundrum here with the challenge of higher mean blood glucoses in African-American patients. And when I think I was and other people were at the mindset when we saw this data, well, you know, these patients, these African-American patients, obviously have higher A1Cs because they have higher mean blood glucoses. Is that so? And we looked at our own data and did two analyses. One is a statistical analysis where we controlled A1C for mean blood glucose, which is down here, and this is the adjusted level. So African Americans had 9.1 versus 8.3 for our white patients. And then you can see here's the HGI difference, and you can see roughly that the difference in A1C, from HGI is about 0.8, and which is very similar to what you get in the mean difference, the adjusted mean difference here. So this is certainly an actionable difference in A1C that has nothing to do with the mean blood glucose. And here's what that looks like statistically. If you had a multiple variable analysis, you can see certainly mean blood glucose is statistically significant. Mean blood glucose goes up, or A1C increases with increasing mean blood glucose. But you can see at any glucose level, the black dots, which are the African American patients, tend to be higher than the Caucasian patients. We've looked at this in a number of ways to try to parse out what might be causing this. Dr. Hamden looked at, and to go back here, if I can. So he looked at red cell indices. RDW CV is significantly associated with A1C, but if you control for that, you still have higher A1C in African American patients. He also looked at whether iron status, and iron deficiency is known to increase A1C, whether that could be responsible, but that didn't explain the difference we found in our patients in New Orleans. We had the ability to actually look at and measure labile A1C, which is not generally measured. We measure the stable Amadori product. And what's interesting is, and this is, the labile is affected very quickly by your current glucose level, but it's not really a reflection of long-term glucose levels. So glucose level is, or A1C level is also higher in African Americans in the concurrent glucose sample that you might measure here, suggesting that perhaps the internal concentration of glucose in these patients tends to be higher than in white patients. Here's a study just recently appeared, and I'm not even sure it's published yet, but it's online, from Diabetes Care by Toshi et al. And what she did was calculate the HGI, although she didn't call it the HGI, using GMI. And if you've wondered, in patients where you're using continuous glucose monitoring, GMI is the glucose management index, which is essentially a way to predict what the A1C would be based on your mean blood glucose from CGM. So if you've been curious as to what to do with that number, here's what you can do. You can calculate the hemoglobin glycation index, taking the patient's measured assayed A1C and subtract the GMI, which is based on population data from published already. And here's Toshi et al. Looked, and she, here again, replicated work that's been done in the past. The non-white patients had a higher HGI than the white patients. And interestingly enough, like the type 1 diabetes exchange data, the patients, now here, this is recorded on CGM, there was more hypoglycemia that was recorded in the CGM in the non-white patients who had HGIs that were greater than 0.5%. Didn't seem to be a difference between the white patients, even though there looks like there is a difference there. This factor seems to be affected by sickle cell trait. Here's some data from the Jackson Heart study. These are patients without sickle cell trait, and this is based on percent European ancestry. So you can see that patients with less European ancestry have higher A1Cs than the patients with more European ancestry. But you can see that patients with sickle trait have altogether have lower A1Cs, and they also have no difference between the high and the low ancestry genes, which would suggest that differences in glycation that we may be looking at may be dampened in patients with sickle cell trait. So the number of patients who may be affected and may be at risk may be much higher unless we fully account for, say, sickle cell trait, which is enriched in this population. So let's take a moment to summarize where we are. Hemoglobin A1C, I hope you'll be convinced that it's not just mean blood glucose, but there are a number of other potential factors which can influence this that need to be taken account of. Non-mean blood glucose variation in A1C has predictive value for diabetes complications. The A1C overpredicts mean blood glucose in Black patients. And you can pick this out by now, if you're using continuous glucose monitoring, subtracting the patient's measured GMI from measured A1C from the GMI you're getting on your continuous glucose monitor. The effect seems to be dampened by sickle cell trait and possibly G6PD, which may use the GMI patients with particularly low GMIs to pick out those individuals that have these problems with hemoglobin. Non-mean blood glucose A1C disparity potentially contributes to increased risk of complications in Black patients, like we saw from the DCC data. I'm not sure what we can do about managing these potential factors yet, since our current methodology of managing A1C using glucose lowering agents might not be effective. And I worry that people who may be using point of care A1Cs and don't have very good glucose data may be over-treating A1Cs in African American patients and causing the hypoglycemia that's been reported in these other studies. Let's move on now to management support factors, which may be influencing racial disparity in A1C. And here again, back to the DCCT again, and I think we have to give these the investigators a lot of credit for being able to keep this large population of patients with a fairly consistent A1C between the intensive and conventionally treated group. The dark secret here is that at any one center, there probably were only 20 patients assigned to a CDE, and that's a far cry from the number of patients per CDEs at our clinic in New Orleans, and I'm sure at your diabetes clinics. And what's very interesting is at the end of the DCCT was another study called EDICT, or follow-up study. Here, the patients who had been formerly conventionally, 2 or 3 shots a day of mixed dose insulin, and here are the MDI and pump patients, and the study was stopped and then to do on their own. And you can see that over time, the A1Cs merged, and my of tech and improved insulin delivery systems, MDI and pumps. And this is a nurse who could call you every week or as often as needed and be in contact with them. Plus the DCCT also gave unlimited nutrition support and psychological support. So there's a lot of support that went into maintaining this difference that after the DCCT is just not possible to maintain in your average diabetes clinic. Here's discussion now. I just want to walk you through this. This is not race now, but the white is pump and the black is MDI. And you can see this is from the type 1 diabetes exchange that often lack of access to tech is given as a contributing factor to glycemic disparity. And you can see here that there is a difference. Here are the white patients, here are the black patients in the second column, and you can see 51% of the white patients under 6 on pumps compared to 32% of the blacks. And you get to 6 to 13, you can see 63% compared to 25%. And so you can see that there is less access or less patients using that. But when you control for the method of insulin delivery, you can see that even those patients using pumps, black patients, are still have higher A1Cs than the white patients, regardless of age, regardless of insulin delivery systems. So something else is going on besides access to technology here. And we thought, well, maybe open loop pumps are not adequate. Maybe if patients have access to advanced hybrid closed loop pump systems where a lot of the management between meals is taken care of automatically for them, would such a device help mitigate that difference between glycemic control? And we looked at our patients who have been put on tandem control IQ since January 2020 when it was introduced. And if you like more details of this, please see Nick Christakis' poster that's in the poster hall. But you can see there was a very nice response of our white patients, and the average A1C is similar to what occurred in the pivotal studies using advanced hybrid closed loop pump, but no change in the black patients. And Nick is continuing to accrue data, and we should have many more subjects to look at this in more detail. But roughly, you can see here what the average difference was. Our African-American patients were averaging 8.5, whereas the white patients were about 7.2 at the end. And then the sensor mean blood glucose difference wasn't as great. And you can see this was about 180 or 90 so versus 160 here. So let me wrap up now and give you some time to comment and ask questions. A1C, no matter which study you look at, consistently overestimates the mean blood glucose in African heritage populations. This non-glucose factors contribute to racial disparity that we see in our patients. In A1C for sure, and potentially in complications. If this is not so, in other words, if A1C has no greater predictive value from what we're getting now from our CGM, then I think A1C is have all the statistical information that you can get from CGM. So I think the future of A1C is going to be based on whether it's still predictive ability. This certainly has implications for diagnosis of diabetes. If African Americans have higher A1C when they don't have higher glucoses, can it really be used or use the same criteria? HGI may be a useful way to put GMI to use. And you may be able to detect patients with hemoglobinopathies and G6PD, and it may have some predictive value for who is going to get complications. And it certainly, we can see whether that boils down to a relationship to higher risk between individuals and groups. There certainly is going to be a need, if this data holds up in the future, for an innovative treatment for this non-mean blood glucose A1C disparity. I don't have good suggestions for that right now. And the other thing is, tech can certainly help improve mean blood glucose and hence A1C, but by itself, current high tech does not erase the A1C racial disparity in A1C. And we look forward to further advances in tech management and patient support, which may ultimately mitigate this challenge of racial disparity in diabetes output. We are currently receives support from NIH for our work. And here are a list of colleagues who have helped in this work over the years. And I'm open to questions at this point. And please remember that March 1st is Mardi Gras, and come to New Orleans and celebrate with us.
Thank you, Dr. Schulhoff. Excellent lecture, as usual. So the presentation is open for questions. We have some questions on the chat. Let me see. All right. So there is.
I saw a question from Millie, and yes. I didn't. It was too quick for me to. Could you read it? It was too quick for. Maybe I can look at it.
So it says, always disheartening to see racial and ethnic disparities with glycemia control. It was striking to see that the Control-IQ technology did not make a difference either, unless I'm not understanding correctly.
No, you got it.
Got it, exactly. Follow-up, did this study notice any particular reasons for why the high-tech didn't?
We're looking into that. Nick is looking through as time goes on. The first thing I should say is that we have a very high percentage of African Americans in New Orleans, and New Orleans is a majority African American city now. We have about 40%. Would you agree, Ricardo? Or 40% African American in our type 1 patients, and yet if you look at Nick's presentation, 40% of our patients are not on Control-IQ. It's they're not getting it. So if you look at access or utilization, we have far fewer. And Ricardo actually looked at who was on pumps, and like the the type 1 diabetes exchange, we had fewer patients on pumps than representative of our population. Nick found, if you go look at his poster, he found that at least initially, the patients on Control-IQ were not in auto mode as much as the patients, the white patients. And he's now looking at bolusing. I suspect that the bolusing is probably going to be less as well. But they were out of automatic mode much more frequently than the white patients. So they weren't using the technology the same as the white patients.
The other question is what is the utility for checking fructosamine in these patients with the blood dyscrasia?
Well, I think fructosamine is fructosamine is very interesting because it's glycated extracellularly. But I think A1C is, since it's has a longer track record, and there's all the data from the DCCT, and anyone that looks at complications is going to get it. we don't have a good handle on what the relationship between that and complications are yet. So it's also a shorter term reflection of what your mean blood glucose is. It does have a place, particularly in patients with renal disease, because very often the red cell lifespan in kidney failure patients it makes A1C unusable. So you'd go to something like fructosamine or glycated albumin to help you with that. But it just doesn't have the relationship with complications that we're used to with A1C.
Okay, thanks. The next one is about the use of the control IQ. So the question says that some of the difference may be due to the lack of knowledge versus forgetting to switch back and forth between auto mode and off control IQ. So I don't know if you have
we're actually looking into that. I thank you for that question. I think you're right. I think we're going to find the and we're going to look and see whether if you gave a DCCT style patient ratio with someone that really will be in contact with the patient and help them with tech and encourage them to use the tech, maybe pay them to use the tech, that maybe we could get better results, if you believe it's a support issue. And we'll certainly, obviously, when you do these studies, you have to factor out what the non-mean blood glucose relationship is. And if you look back, I didn't specifically show it, but these patients also have higher A1Cs if you control for the mean blood glucose than the white patients. It's quite striking. And it's a good deal of the A1C difference, because as you could see, the sensor glucose data was much closer than the mean blood than the A1C data. So this is going to be an interesting thing to follow in the future, now that all of you can look at the disparity between what the GMI is and what the observed A1C will be.